Okay, I'm ready to go. I have the recording started. So the first thing is fetal circulation and the transition to extrauterine circulation. So you'll have to know what is different with fetal circulation compared to adult circulation. And of course, that's referring to the shunts that are going on. When the baby is born and the circulation switches over, why does it switch over from fetal circulation to adult circulation? So you have in your notes that when the umbilical cord is clamped, it causes a lot of systemic vascular resistance, and that makes the pressure on the left side of the heart a lot higher, which shuts the foraminal valve. Acidosis from no utero-placental oxygenation causes acidosis, hypoxemia, which makes the baby take a deep breath. That dilates the pulmonary vessels, and now there's low resistance in the pulmonary circuit, and now you've got your adult circulation. The high resistance in the left side of the heart closes the foraminal valve. So when the baby is born, we evaluate them a couple ways, and the Abg'S scoring is number 5. Let's see. Okay, so I'm going to come back to that when we're on number 5. I have all the heart, like if the heart rate is greater than 100, you observe. If it's 60 to 100, O2, possible positive pressure ventilation, but I'll talk about that on number 5. All right, number 2 is pulmonary maturity. To know when surfactant is developed and the baby can sustain the alveoli staying open, we want to know if the surfactant is mature. One of the ways of doing that is using the amniotic fluid and doing LS ratio testing, where you're looking for lecithin to be twice the concentration as sphingomyelin. And that tells you that, yes, surfactant is mature. Another one is the shake test, where you mix the amniotic fluid with alcohol. And if there is enough surfactant, then bubbles will form. So you're looking for bubbles. With delivery, if it looks like mom is going to deliver prematurely within 24 to 48 hours before delivery, mom can be given glucocorticoids or steroids that will go through the placenta into the fetus, and it'll help the surfactant to mature pretty quickly. And next, it talks about fetal hemoglobin. How is it different from adult hemoglobin? Well, fetal hemoglobin has a stronger affinity for oxygen. Therefore, their oxygen saturation is higher for a given PaO2. For example, a PaO2 of 30, fetal hemoglobin saturation will be 75%. But on an adult with a PaO2 of 30, saturation will only be 65%. So stronger affinity, which way does that shift the oxyhemoglobin dissociation curve? To the left. Very good. A normal PaO2 in utero is 30 millimeters mercury. Normal pH is 7.30. So those are the conditions that fetal development occurs, and that's considered normal. During labor, the heart rate changes during contractions, and depending on what the heart rate does, you can tell if there's compromised blood flow to the fetus during labor. So with the belts around mom, if a contraction is noticed in one belt, the fetal heart rate is monitored with the other belt. If the heart rate decreases early on during the contraction, that's caused by head compression and vagal stimulation, and that's considered okay. But if there's a contraction and the heart rate slows down later in the contraction, that tells us that the placenta is being compressed and uterine blood flow is being compressed, that's not okay. So at that point, they may decide to do a C-section and deliver the baby. For heart rate changes during contractions, oh, we did that one. Under that, I also have what suppresses labor. So if it looks like mom's going into premature labor, we want to stop the labor, what could be given to mom? And that's magnesium and a beta-2 agonist given orally or IV will relax the smooth muscle around the uterus. What drugs are given to speed up labor? Pitocin. Pitocin is the brand name, oxytocin is generic. Okay, for Abg'S scoring, Abg'S scoring is done at 1 minute of birth and at 5 minutes of birth. And then the APGAR, so your appearance, your pulse, your grimace, activity, respiratory rate, and you come up with a score. If everything's great, you have a score of 10. It used to be, I mean, now we go by heart rate and we talk about if the heart rate's better than 100, observe, etc. It used to be, it went by Abg'S score. And if the Abg'S score was 7 to 10, observe. 4 to 6, you give oxygen and gentle stimulation. Abg'S score less than 4, you start positive pressure ventilation and possibly CPR. Okay, so now let me do the heart rate since it kind of falls under Abg'S scoring. So heart rate greater than 100 and no respiratory distress, all you do is observe. If the heart rate is between 80 and 100, you typically have low oxygen saturation. You would want to start positive pressure ventilation. And when you start positive pressure ventilation, you want to start with 21% on preemies. If they're more than 35 weeks, you can start with 30% for your FiO2. If the heart rate is less than 60, then you start compressions. So you don't wait for a heart rate of 0. Less than 60, you start compressions. If the O2 sat is 60% at birth and not increasing, what could you do? So if your concern is low O2 sats, not necessarily the heart rate being a problem, but just that the O2 sats should keep increasing after the first several minutes of life. And if it doesn't, it stays at 60%, what would you do? You can do mask Cpap with the Neo-T. And you increase your FiO2 to get around 65 to 70% for your O2 saturation. Number 6, gestational age assessment. This shows if the baby has the neuromuscular maturity they should have according to their gestational age. It's called the Dubowitz-Ballard assessment for neuromuscular maturity. It's done 30 to 48 hours after birth. It also meant, well, I'm repeating myself. It's to see how babies developed in utero and to measure their intrauterine growth. LGA stands for large for the gestational age. S stands for small for gestational age. And A is average for gestational age. So small for gestational age is from poor placental blood flow or poor nutrition. Next are vital signs of the newborn. So full term is heart rate 100 to 180 per minute. Blood pressure can range from preemies having a blood pressure of 40/20 to full term having 70/40. Heart rate, blood pressure, respiratory rate 30 to 60 per minute. And then by the time they're 6 months to 1 year of age, normal heart rate is 100 up to 120. Their blood pressure is 90/60 or 100/60. Respiratory rate is now 24 to 40. And then to figure out blood pressure for a child more than 1 year of age, you do 90 plus 2 times their age. And the diastolic is typically 30 millimeters mercury less. When a baby is born, the cricoid cartilage is the narrowest part of their airway. The larynx is shaped like a funnel. They are obligate nose breathers. So they have a really large tongue. So it's hard for them to breathe through their mouth. So they'll breathe through their nose. So if their nose gets plugged, it causes them difficulty breathing. Number 8, the neonate's response to hypoxemia is A, B, and D, apnea, bradycardia, and desaturation. So if they're hypoxemic, they will breathe fast, try to get their O2 sats up. And if their O2 sats don't come up, it causes them to become apneic, causes their heart rate to drop. And you'll notice that their O2 saturation goes down. Also to note about a neonate's response to hypoxemia is it causes the pulmonary vessels to constrict. So pulmonary vasoconstriction. If they don't get oxygenated after that primary apnea, they do go into a secondary apnea where their blood pressure falls and they become unresponsive to stimulation. It's almost like a respiratory arrest at that point. It's called a secondary apnea. So apnea, bradycardia, desaturation lead to a drop in blood pressure and infant becomes unresponsive to stimulation. So that's secondary apnea. Silverman scoring is an assessment of infants in pediatrics, and we're looking for work of breathing. So if their work of breathing is normal, they have a score of 0. And then if they have severe respiratory distress, they get a score of 10. So 10 is bad. The categories for the Silverman scoring are looking at the upper chest, the lower chest, xiphoid process, the nares, and expiratory grunting. So next for neonatal pulmonary diseases. These are the ones that you need to know. And I know there was other ones in the PowerPoint or when we were talking about neonatal diseases or conditions. We decided not to call them diseases. So you have to know about respiratory distress syndrome, bronchopulmonary dysplasia, or its newer name, neonatal chronic lung disease, transient tachypnea of a newborn, the causes of retinopathy of prematurity, and where we should keep O2 sats to avoid that, PPHN, pulmonary interstitial emphysema, and meconium aspiration syndrome. So you need to know the cause, who it affects. Sometimes it affects premature babies, sometimes it affects full-term babies. You need to know the clinical findings, including the chest X-ray, and you need to know the treatment. So for X-ray, I have a list of X-rays that are on the exam.
You're so kind, Professor.
Oh, you're welcome. Where's my annotate? No annotate? Is it annotate an app? All right, so guess I need to put it in the chat. So I'll let you guys write this down because I know the chats don't show up when you listen to the recording. The first one, it's tiny blebs throughout lung fields. Tiny blebs. Throughout lung fields. And that's going to be pulmonary interstitial emphysema, PIE. Tiny blebs throughout lung fields is pulmonary interstitial emphysema. This one is old. It might be on this final exam, so I'll still mention it. It's 4 stages from whiteout to eventually looking like Swiss cheese. So 4 stages on a chest X-ray begins with whiteout from the severe RDS. So baby was born premature, lacking surfactant. Eventually, the X-ray looks like Swiss cheese, and that's bronchopulmonary dysplasia. So 4 stages on the X-ray. It begins with whiteout from severe RDS. Eventually, the X-ray looks like Swiss cheese. And that's because of cystic areas of emphysema from the damage from mechanical ventilation. And the babies end up with BPD, or bronchopulmonary dysplasia. So that's old. I don't know if they still put that on your national exam. But that's what the x-rays looked like before surfactant was a thing. Now with surfactant, the lungs don't get as bad. And we also know not to leave them on a ventilator for weeks at a time just because they're premature. Try to get them off and just use nasal Cpap, and that protects their lungs also. The next one is streaky interstitial pattern with engorged lymphatics. So streaky interstitial pattern with engorged lymphatics. And that occurs with transient tachypnea of the newborn, where the fluid that was in the conducting airways, it gets cleared pretty quickly when everything is normal. But sometimes there's delayed clearing of all of this lung fluid. And the baby will have they'll be breathing really fast because of it. Causes like low lung compliance, so they'll be breathing fast. You'll see an interstitial infiltrates, but that's just from the engorged lymphatics trying to drain all the lung fluid after birth. So streaky interstitial pattern with engorged lymphatics. You're looking at transient tachypnea of the newborn. The next one is diffuse ground glass appearance with air bronchograms. So diffuse ground glass appearance with air bronchograms. You're looking at respiratory distress syndrome. Indicate the location of pre and post ductal pulse oximetry sites. Pre-ductal is the brachiocephalic artery. That is like the first branch of the aorta. And the brachiocephalic artery receives blood coming from the left ventricle. So that's blood that did make it to the lungs, came back to the left side of the heart, and goes into the aorta. So the brachiocephalic will get the freshly oxygenated blood from the lungs. So that's considered pre-ductal. And then after that branching on the aorta is the ductus arteriosus. And if there's blood going from pulmonary vessels through the ductus into the aorta, it's going to show up after that first artery on the aorta. So everything else is considered post-ductal. So typically the umbilical artery can be used either leg. So I know some of you think it's got to be the left leg or the right leg, but no, it's the descending aorta. Any places on the descending aorta are going to be post-ductal. So that could be the right leg or the left leg.
Pre-ductal will be just like the right hand.
Yes, and pre-ductal will be the right hand. Pre and post ductal PO2 measurement is most useful for evaluating what?
PPHN.
PPHN, very good. So if pulmonary vascular resistance is high, blood will take the pathway of least resistance and go through the ductus arteriosus into the aorta instead of traveling to the lungs for oxygen. During surfactant therapy, you're putting the surfactant down the conducting airways with the thoughts of it being absorbed into the alveoli. But during surfactant delivery, the patient might desaturate. What could cause this?
Occlusion.
Very good. The thick surfactant is occluding the conducting airways. Also, a pneumothorax can happen because you're having a rapid change in compliance in the alveolus and it can pop. So trans illumination of the chest to rule out a pneumothorax. Know what results indicate a pneumothorax and what results indicate normal lung tissue. So when you see a pneumothorax, the word hyperlucent is used, meaning that the light shines really bright because the thorax is full of air and the lung tissue has collapsed. So all of that air in the thorax, it's going to cause the light to shine brightly. So it's called hyperlucent. And then what results indicate normal lung tissue?
Just regular lucency.
I know,
I don't know.
hyperlucent
Hypo.
wouldn't be hypolucent. Normolucent. Okay, and now we come to normal Abg's and Cbgs in utero and post-birth. In utero, we expect, I think I gave it to you previously, a pH of 7.3 and PaO2 of 30. I didn't give you a CO2 in utero. So probably 50 millimeters mercury for capillary blood gases taken from the fetus. So how can you get a blood gas from a fetus? Once the water breaks and the head starts to present, it's possible to get some scalp blood and analyze the scalp blood to see how the fetus is doing. So this is, I guess, as delivery or as labor is beginning, the scalp becomes available, and that's how you can get a fetal pH or a fetal blood gas.
So you stab the baby in the head?
Yeah, I know, it's cruel.
Why did you stop the brain? Why did you-
You can't stop the brain by putting a needle in the scalp. Oh, stab, S-T-A-B.
Yeah.
Oh. So you go almost parallel to the surface of the scalp. Instead of going straight in, you're going to the side when you do it.
Okay.
Can you just do it like how we do the split, you'll just poke it and get blood from capillary?
Yeah.
It's like a lancet.
Yeah.
You just
Exactly.
get the blood in. Okay.
Yeah.
I have a question about getting blood from ABG in general, like, because in lab, we learn to go in on an angle, but at the hospital, some of the nurses, like, they tell us that you're supposed to go
Yeah.
straight up and down. Yeah,
90 degrees.
yeah, they're like, why are you holding it like that? You have to hold it straight up and down. So I was just curious.
Wow. Yeah, I've never heard of going straight up and
They
down.
told me you're doing it wrong. Do a 90-degree angle.
Everyone has their own method of this.
Yeah, who's telling you to go at a
Other therapists, if they're in the room with us, heard it a couple of times. So I was just wondering if that was, if anyone else had heard that, if that was like a new thing or.
Yeah, that's new to me anyway.
See, and that's confusing, because it's just a little confusing, because if everybody has a different way.
It really is for you guys. Oh my gosh. I really feel for you. You get different things from different instructors, and then you get different things from the staff therapists, and how are you supposed to know what to do?
Right.
Yeah, it's, I think one of the biggest challenges that you come across being new in the field. And the normal ABGs, after birth, you expect a little bit of an acidosis once they're delivered. Because there's been a period of time during that transition where they haven't started to breathe yet. So during the delivery, they're going to have higher CO2s, low O2s, a little acidosis builds up. So you would expect like the acidotic side of normal when they're initially born. And then within 1 hour, the ABGs look like that of an adult. The safest place to stick an infant for a capillary blood gas is the lateral posterior side of the foot. You avoid the curvature of the heel. Of course, you have to warm the heel to increase the arterial flow, so you're not getting too much venous blood when you do stick. It's not good to squeeze too much. You get a lot of fluid from that area. That also comes in the tube with the blood. Air bubbles change the result. Clots are not good. If the baby is crying, that changes the values also. So you're looking more for pH and CO2 when you're drawing your capillary blood. How to give supplemental oxygen to a neonate and a pediatric patient. So we've got high flow cannula, nasal cannula to a blender, oxyhood. That might still be on your national exam. I don't know if they've taken it off. We need to hear from Danielle tomorrow before we know exactly what's happening with oxyhoods. But if I think it's a question on your final next week, and you have to know what the parts of the setup are. So you don't use straight to the wall, you use a blender. And you have to warm the air that's going into the oxyhood. So to use Fisher-Paykel heater and humidifier would be good. So you're heating the air, and with an oxyhood, you need a flow of at least 10 liters per minute so they don't start rebreathing their exhaled air. Number 16, select endotube size, laryngoscope size, and vacuum setting for infants and children. So you'll be given a scenario and you have to select the size of endotracheal tube. Do you have this in your minds yet? So if they're really premature, they get a 2.5. If they're premature but big enough, they get a 3. And if they're normal 40-week gestational age, you can use 3.5 to 4. Okay, so you need to review that. The 00 is used for those extreme preemies. And then for normal size gestation, a 0 or a 1. As far as picking out an endotracheal tube for children, it's age over 4 + 4, which you guys have in your notes, so you can review that. Indications for Cpap. So if the baby has increased work of breathing, low O2 sats, then nasal Cpap is indicated. There's PaCO2 has to be good. So if their CO2s are high, and high is what, greater than 50? So if their CO2 is higher than 50, you don't want to just give them more nasal Cpap. That indicates that they need to be ventilated, and you would put them on a ventilator. So that's intubation and mechanical ventilation. But if they just have grunting, signs of respiratory distress, and low O2 sat, then you would recommend nasal Cpap for those babies. Number 18 is transcutaneous monitor. Troubleshoot why readings don't agree with the Abg. All right, with a transcutaneous monitor, carbon dioxide in the arterial blood diffuses very easily through skin, and is picked up by a transcutaneous monitor, so it trends very closely to what the arterial blood shows. Oxygen, not as much. So you might have like a 10 torr difference between your arterial blood gas and what's showing up on the transcutaneous monitor. So oxygen is not as diffusible as carbon dioxide. If the skin is not warmed up, you're not going to get a good result. Skin thickness makes a difference as far as accuracy. The thicker the skin, the less the gases will diffuse through the skin. If there's poor perfusion, again, the readings won't agree with the blood gas. And if there's pressure on an area of the skin, that's going to decrease perfusion to that area. And again, the readings won't agree with the blood gas. Number 19, choose normal ventilator settings for a newborn being placed on the ventilator. So the modes of ventilation, for ventilating. So a rate of 40, typically tidal volume 4 to 6 mLs per kilogram. But what mode is used with newborns? PRVC, have you guys seen PRVC on newborns? Oh, really? Okay. Yeah, so typically pressure control, whether it's TCPL or SIMVPC. And then the volume guarantee if they're using a via ventilator. So those are modes of ventilation. And now for settings. Rate of 40 per minute, what you start with. Inspiratory pressure is 15 to 20 centimeters water. You'll use oxygen to get a sat of 88 to 95%. PEEP of 5. So when you're using a peak pressure of 15 to 20, you're trying to target a 4 to 6 ml per kilogram tidal volume. Calculate the portion of the exhaled tidal volume reading that stayed in the circuit if volumes are being measured at the exhalation valve. So you have that in your notes, the formula that you need to figure out how much stays in the circuit, how much actually goes into the lungs. Because typically when you're seeing your exhaled tidal volumes, It's showing the volume that was in the circuit as well as the volume from the lungs. So you get this big volume out and you think, oh my gosh, it's a lot of volume going into the lungs. But then when you do the calculation, you realize, no, that's not the case. Number 20, weaning from mechanical ventilation. You wean down to a rate of 10. And once you get them down to a rate of 10, you don't go any lower because of the small endotube and all the airway resistance and breathing through a small endotube. So at that point, they should be ready for extubation to nasal Cpap. So the answer to the question, no, it's best to extubate to nasal Cpap. And then we got into cardiogenic abnormalities, and the ones that are listed there are the ones that show up on the exam. So PDA, tetralogy of Fallot, coarctation of the aorta, ventricular septal defect, and AV canal. You need to be able to describe each of the abnormalities and be able to tell which way blood is being shunted. I'm not sure I clarified this in your notes, like when you go back and you're looking at the anomalies. But for AV canal, I have in my notes that it starts off as a left to right shunt, because the pulmonary vessels at that point are very distensible and normal. But then pulmonary hypertension develops over time, and then it becomes a right to left shunt. I've already said that. Oh, okay. I thought I missed it. Okay, list the ductal dependent lesions. So hypoplastic left heart, we have to have a ductus arteriosus stay open so that blood can get into the aorta, because the left ventricle is not able to push much blood into the aorta. So the way for blood to get to the aorta is through the ductus arteriosus. So yes, we need that ductus arteriosus to stay open if the baby has a hypoplastic left heart. In transposition of the great arteries, the only communication between the two circulations is the ductus arteriosus. Next one is coarctation of the aorta. Again, because of the coarctation, it's hard for blood to get into the aorta. So we need the ductus arteriosus. Also to relieve pressure. And then tetralogy of Fallot. Because the pulmonary artery and pulmonic valve aren't developed well, we need the ductus arteriosus for blood to get into the pulmonary artery. When is subambient oxygen therapy indicated? We use subambient oxygen therapy, meaning less than 21%. If we want to keep the pulmonary vessels constricted. So remember that hypoxemia causes the pulmonary vessels to constrict. So if we want to constrict the pulmonary vessels, we keep the babies hypoxic or hypoxemic. It might be necessary to use less than 21% in order to do that. So to reduce pulmonary blood flow in babies with AV canal and in hypoplastic left heart, we need subambient oxygen therapy. Number 22, Indicate the criteria and methods used for extracorporeal life support or ECMO. If the oxygenation index is greater than 40, that's one of the criteria. If the alveolar to arterial oxygen gradient is greater than 600 on 100%, that's another criteria. It has to be babies greater than 34 weeks with no head hemorrhage. They have to have a reversible disease. Two different ways to do ECMO. One is veno-venous, where the blood is taken from the right atrium or the internal jugular and put into the right atrium. And then there's veno-arterial, which actually helps the heart to pump the blood to the body. And that's when the internal carotid artery, left common carotid artery is cannulated and blood is put into the aorta. And this helps circulate the blood with a failing heart. Number 23, indicate the indications and hazards of nitric oxide therapy. So it's approved for persistent pulmonary hypertension of the newborn. If they're greater than 34 weeks of age. Some of the hazards of nitric oxide therapy is if the gas becomes stagnant, a toxin forms, nitrogen dioxide. It's very toxic to lung tissue. Methemoglobin might form with higher doses. And there's a rebound effect if nitric oxide is weaned too quickly or stopped. It causes rebound hypertension. It's been about an hour. Should we just muddle through the rest, or do you guys want to take a break? Okay, there's only a few left. What's that?
I was just saying there's like 4 left.
Okay. List the causes of croup and epiglottitis. You guys are up to speed on this, right? Because you just took your test. So we know that croup is viral, epiglottitis is bacterial, croup hits the younger kids, epiglottitis a little bit older. Croup has low-grade fever, epiglottitis, high fever with sudden onset. The epiglottitis kids are drooling a lot and they sit forward trying to open their airway. Epiglottitis isn't considered an airway emergency. So to take a look with a laryngoscope to see if the epiglottis is swollen, that's enough to cause it to swell more. So typically the kids are intubated in the OR, just in case a trach needs to be done. The treatment for tracheomalacia in infants is to place an airway stent. We know that the cartilage softened either from mechanical ventilation or from the endotracheal tube rubbing on the walls of the trachea that can also erode and soften the cartilage. And we know when they breathe in, their airway collapses. So putting in a stent or using Cpap to keep that trachea open is the treatment. Recognition and treatment of obstructed airway. So having partially obstructed airway, you have a sudden onset of coughing in a baby that was normal a few minutes ago. Complete obstructed airway, they turn blue. You'll see the paradoxical chest movement indicating that you have an obstructed airway. To clear the airway, it's back blows and chest thrusts in the infants. And then if they're over 3 years of age, you can do Heimlich maneuver. Tracheostomies, you need to know the types of trach tubes, what to do if the trach tube comes out, when to decannulate, and precautions when using a Passy-Muir speaking valve. Oh, that's it. So there's no head trauma on? That's it. Okay,
And this was recorded, right?
yes.